Welcome everybody to the first virtual AIOC 2021 subspecialty day. And I would like to thank the scientific committee for the opportunity to discuss on this forum. The anterior segment OCT is pretty useful in
Dr. Aravind, you are on mute.
Am I audible?
Yes, you're very much audible. Please go ahead.
So the anterior segment OCT is based on the Michelson's interferometry, where the light source from a 830 nanometer diode is split to image the anterior segment, and the reflected images are used to image the anatomy of the anterior segment. This can image the cornea with variable degrees of accuracy, usually between 2 to 3 micrometers and up to a depth of 6 to 12 millimeters. The speckled appearance of the images is basically because of interference from adjacent study points. It can have varied applications in the diseases of the cornea, and it also has a wide array of research applications. We shall be discussing a few of the clinical applications followed by the research applications, and one such important use is that in meibography. So as we can see in normal eyes, the meibomian glands, when they are imaged at the orifices, the distal, mid and proximal segments are uniform, whereas when they are compared to that of a patient with meibomian gland disease, the mouth of the meibomian orifices are plugged and the lumen is distorted and there is a dropout of glands. The RT view can also provide a map of the epithelial thickness, as we were discussing some time ago, that the epithelial thickness changes are pointers towards subtle corneal ectasia, thereby alerting the refractive surgeon against an intervention in these cases. So when we see in the top panel, there is a normal appearing pachy, but when we see the epithelial thickness, there is a thinning pertaining to an area of a possible early preclinical ectasia. The OCT is very useful to image a wide array of clinical findings in keratoconic eyes. The keratoconic eyes can also show hydrops which will be appearing as cystic spaces. There might be areas of scarring, and this is a miniscleral lens which is on position of the cornea, and the stability of intracorneal ring segments. Collagen cross-linking is the single most important intervention that we have in preventing the progression of keratoconus. Therefore, the OCT can help image whether there are areas of hyperreflective anterior stroma, which is corresponding to the extent of the collagen cross-linking. These are shown by the white arrows, which show as a distinct prominent line in the anterior stroma. In pediatric corneal opacities, the imaging of the anterior segment helps the surgeon plan for the surgery and show whether there is only a scarring or whether there is underlying scarring with iridocorneal adhesions. In corneal ulcers, there are areas of necrosis, cystic spaces, cellularity, stromal infiltration, and retrocorneal membranes. The corneal foreign body might show a distinct backshadowing, areas of sealed corneal tears, and stromal cellularity. In corneal dystrophies, OCT helps to localize the depth and extent of the corneal deposits. In granular corneal dystrophies, these are typically subepithelial with backshadowing. In Fuchs dystrophy, there is a prominent Descemet membrane with endothelial guttae, and often there might be subtle subepithelial hyperreflectivity due to scarring on the anterior cornea. Thygessons usually shows hyperreflective epithelial lesions with backshadowing into the cornea. When there is a non-resolving corneal edema, there might be subtle localized Descemet detachment. This is useful in planning a descemetopexy. There are several research applications where OCT is also used for grading the inflammation and cellular reaction in anterior chamber. This has been found to be very consistent with cytometry-based gradings. Similarly, in animal models of corneal infection, the grade of edema in the corneal tissues correlates with the grade of edema on histology. These are CXCL1 mice on which Pseudomonas aeruginosa infection has been induced. And one can see that there is a very good correlation at 12 hours between the histology and the OCT. Immune stain antibodies, which are placed on the mice cornea, can show up as deposits. These needs to be checked on histopathology, and this is what is displayed is a flat mount of the mice cornea. When a OCT-based imaging is done to image the corneal endothelial deposits, then it was found that it correlates very well to histology and also in vivo confocal scanning. The histology typically overestimates the endothelial deposits, whereas the OCT whereas the confocal based imaging underestimates the endothelial deposits. But there is a very good correlation between histology OCT and confocal versus OCT. The relevance of these studies are that in vivo imaging permits longitudinal studies in the same animal over time. Therefore, it increases the efficiency of the experiment. Drug delivery is another challenge, and drug delivery vehicles promote increased retention on the ocular surface so that the drug does not run out from the ocular surface. So when there is a hydrogel-based drug delivery, as we can see, the white arrows show that the hydrogel-based drug delivery vehicle allows retention on the ocular surface for up to 60 minutes, whereas a drug that is delivered with PBS, which is phosphor buffer saline, runs away usually by the first hour itself. And the OCT-based imaging provides conclusive data about how the drugs stay on the corneal surface. The future of OCT is to have a micro OCT where a cellular level scanning can be performed. However, it is limited to a depth of 150 microns. Next levels imaging includes the fluorescein imaging so that a structural and cellular data can be simultaneously obtained. All in all, the OCT is a very simple and useful, non-invasive way which can be administered as an office procedure and can be used for a wide variety of corneal and anterior segment diseases, and it also has a multitude of research applications. I would like to thank all of you for a patient hearing, and we look forward to these sessions.